This week on the BackTable podcast.
Another setting I feel really excited about is to use these radioligand therapies in oligometastatic setting as a way to delay ADT. And there are many patients who will be very interested in this approach down the line.
Yeah, that makes a lot of sense. It seems like in the oligometastatic setting, the challenge is in targeting, right? And a radioligand with a bound to a targeting molecule or something, sort of overcomes the limits of what we can target with imaging. So I think that makes a lot of sense to me.
And that becomes more exciting with these newer, with the newer agents like the actinium, the alpha emitters, because the beta emitters, the concern is that if you don't have enough of a critical mass of tumor there, then you won't have enough radiation to kill with the beta emitter. But if you have an alpha emitter, then you could do a better job with micrometastatic disease.
Very good point.
So hopefully that plays out.
Well, I'm really excited to start out this episode on prostate cancer with two experts in the field. We have Dr. Neeraj Agarwal from the University of Utah Huntsman Cancer Institute, a GU medical oncologist, and Dr. Tyler Seibert from the University of California, San Diego, a radiation oncologist. Welcome, guys. Thank you for joining me.
Thank you.
Thank you.
So this is, I think, a great opportunity for us to have a nice discussion about some of the different aspects of prostate cancer care, get a multidisciplinary perspective, and for me to learn a little bit from you guys about what's new and how you think about some of these challenging situations in prostate cancer. So to get started, I think perhaps we can start with the lowest risk situation in prostate cancer. I'm thinking of low risk, Gleason grade group 1, localized prostate cancer, patients that in the surgery world we predominantly recommend active surveillance, and some recent data that suggests that a growing proportion of these men are treated by radiation oncologists or are, I should say, managed by radiation oncologists and often offered active surveillance as well. So Tyler, can you tell me a little bit about how your discussion with patients go when they see you and how you in general do active surveillance?
Yeah, absolutely. So I think this is critical, absolutely important for our patients that we obviously recommend needed treatments when they're needed, but just as important to not overtreat patients. For one, because obviously you impact that patient's life and give them side effects that they don't need. But on a broader scale, the overtreatment that happened, especially in the 90s and 2000s, is one of the biggest or is the biggest barrier to good early detection programs that could prevent metastasis and death from prostate cancer. So really, absolutely critical that we get this right as much as we can so that we do right by our patients and by the population and help to facilitate better detection in the future so that we can prevent the worst cases. This is a disease that often I think people forget. There's even patients come in and they say, well, I heard that you're more likely to die with it than of it. And it's nice that they've heard that and that they understand the concept of overtreatment, but then the nuance is lost, right? They might come in with like oligometastatic disease and they say, I heard that you're more likely to die with it than of it. Say, well, yes, if you have grade group 1, right? But we also know that it's the second leading cause of cancer death for men in the United States. So you can't forget either thing. There's a real risk of overtreatment at the low end, but also still lots of people are dying from it, and we need to do right by both of those groups. So for me, grade group 1, almost without exception, truly almost without any exception, they belong on active surveillance. And I explain to them just that I go through the data. I'm a very data-oriented person, my training in engineering as well, and PhD in engineering. So that's how I think. But and also as a clinical trialist, I like to look at clinical trial data and outcomes. And so I usually walk them through and I explain usually the PROTECT trial and said, this is what we thought at the time. Everybody thought you needed to treat all prostate cancer. And then this trial was done. We now have 15 years of outcomes. Some of these patients have been followed for over 20 years. And we know that delayed treatment is not a problem for the vast majority. There's no impact on survival for early treatment. And there's a very small difference in even risk of metastasis, which is predominantly among those who have a higher risk among these kind of lower risk patients type of prostate cancer. And I think that nuance is even being fleshed out more. You mentioned grade group 1, and I said that I basically always put them on active surveillance or strongly encourage. I will not treat grade group 1 without some kind of crazy extenuating circumstances. For example, patient who needs a transplant, a lung transplant, and you cannot get them up on the transplant list if they have an active cancer, even though it doesn't make any sense and the grade group 1 shouldn't count, whatever. Push comes to shove. But that's the kind of extreme I'm talking about. Grade group 2, though, grade group 2 is often thought of as maybe eligible, maybe not. But I think it's very important for patients to understand that the patients on Protect, the ones who went to radical prostatectomy, 50% of them, approximately 50%, had grade group 2 or higher cancer. And what we think of today as, when we talk about a grade group 2 today, often that patient would have been grade group 1 by systematic biopsy alone. And so it's the same patients. It's just we're better at finding the cancer now because we have MRI guidance and everything. So I think it's very important for us to not only draw a hard line on not overtreating grade group 1 cancer, but also to be very conscientious and thoughtful about grade group 2. Because many grade group 2 cancers will do just fine with active surveillance.
Yeah, I think that's a great point.
That's probably where I spend the most of my time talking about active surveillance, because, the urologists in the community here have gotten really good at talking patients, through the evidence and everything, getting them a grade group 1 to not need treatment. So some who are very concerned will come see me, but most of those I never even see them. But grade group 2 is where they've already had 2 different doctors from 2 different specialties tell them you need treatment. And then undoing that is, takes a lot of time, as you know.
Yeah, absolutely. I think you alluded to, and I think it's true in many facets of prostate cancer, probably we'll talk about some of them today, where good risk stratification is so essential for good counseling. And I think to get at that question a little bit, besides MRI, are you using, for your grade group 2 patients, any kind of adjunctive testing, molecular testing to help beyond biopsy and MRI results?
There are lots of products out there. I'm not here to sell anyone or anything, but the ones that we use the most are Decipher and Artera. They have good evidence for association with the outcomes that I care about, like metastasis. And we use those pretty routinely. We also very big supporters of clinical trials, trying to understand how these things should be used. So we've been running the NRG Oncology trials, GU009 and 010, and those are both using Decipher to decide whether to intensify or de-intensify treatment. They're both randomized trials. And so usually that's my first go-to strategy is if you have an intermediate risk, we put them on the trial. We say if you have a high Decipher, then we're randomizing you to intensified hormonal therapy or not. And if you have a lower Decipher, then we're randomizing you to either getting ADT at all or not. And then for the high risk, it's a similar stratification where it's a high, we intensify, low, we randomize to de-intensification. I think that's a good logical strategy.
Okay, wonderful. I want to shift a little bit to patients who are getting local therapy. For those patients you're treating with radiation, is there a preferred approach for you today as far as fractions, adjunctive technologies, things that you're using for your straightforward localized prostate cancer patient?
So there's a few different things there. We have a couple of decisions. We have to decide how many fractions or how many treatments of radiation to give. And we need to decide what dose to give for that fractionation. And then there's brachytherapy, which is internal radiation. So, in the interest of time, I'll try to give kind of there's lots of nuance and everything, but just what am I thinking, broad strokes. I'm not too concerned about the number of fractions. You can do kind of a long course. We used to always do 8 to 9 weeks of everyday treatment. That was the standard for decades. That's rarely necessary anymore. It works fine. There's nothing really wrong with it, except that it takes too much time, too many visits for the patient. You can go faster. The downside is a very small, modest increase in risk of side effects, not of really severe side effects, but of grade 2 side effects. And then so it really is just a matter of patient convenience versus small difference in side effect risk. A vast majority of my patients are either going to get in the 4 to 5 week range now versus only 5 treatments, which is SBRT. And it's really that trade-off. When I'm treating lymph nodes for higher risk patients, then I tend to do the the longer course, the 2028 kind of treatment, not 5, because I'm not sure that we've totally fleshed out how to do the 5 without as many side effects for our lymph nodes. But for just the prostate, it doesn't really matter to me which way we go. And I give the patients the option and they can decide if it's convenience or side effects that they prefer, side effect, reduction that they prefer. And many will choose either way. Then the next question is dose and approach. So the ways of intensifying radiation are to do internal radiation with what we call brachytherapy, or a focal boost of the radiation dose. So for lots of reasons, I prefer the focal boost one. I mentioned my preference for looking at evidence. Internal radiation brachytherapy, the best evidence for it in terms of randomized trials was ASCEND-RT. That was intermediate and high risk patients. They got a year of hormone therapy, and then they either got all their radiation to the whole prostate as external beam, or they got external beam to, is like 45 gray, I think. And then they got a boost with brachytherapy. And the bottom line on that trial was a big difference in biochemical recurrence rates, but no difference in any other endpoint, except a lot more toxicity, including grade 3 toxicity with the brachytherapy. So I don't find that very compelling. You get a lot more toxicity, you lower the PSA more, but you haven't prevented metastasis. So I'm not sure if that's a great deal for your average patient. The newer approach was studied in the FLAME trial. So this is a trial in the Netherlands, randomized controlled trial, phase 3, that took advantage of what we now have, which is MRI allows us to see the tumor. So I tell my patients, if we had known how to see the tumor back when people started radiation for prostate cancer, the normal, natural thing to do would have been focus the radiation on the tumor. But because we couldn't see it, and we knew the radiation, we knew that prostate cancer could be multifocal. It's often in multiple places in the prostate, and I can't see where it is anyway. I have to treat the whole gland. And that follows because surgery was also removing the whole gland. It made sense. But now that I can see the tumor, I love the approach that they took in that FLAME trial where they said, we'll just treat the whole gland, but we'll intensify the radiation dose to where that tumor is, where I can see it on MRI. And they did that without increasing toxicity because they only increased the dose for each patient as high as they could get away with without overdosing nearby organs, the bladder and the rectum, for example. And the result was, again, a difference in biochemical recurrence, also lower recurrence rates in the prostate, and lower recurrence rates outside of the prostate, which they called regional plus distant. So it was either lymph nodes of the pelvis or beyond, or bone metastases. And there was a reduction in that regional or distant metastasis-free survival without an increase in toxicity. So that one's a freebie, right? From a patient's perspective, you tell them, look, I can treat you 2 ways. One way, the old way, works pretty well, works great. Or I can do this new way. You don't have to come any extra times. You don't even know it's happening. The patients were blinded on the study. There wasn't an increase in side effects, but you're more likely to be cured. There's nobody in their right mind that would say, give me the old way. So I'm all for the new way. I don't know what, your interests we can talk about, but that is not the most common thing in radiation oncology right now because of several logistical and educational barriers that we need to overcome. And my research group spends a lot of time trying to overcome those.
Okay, fascinating. Yeah, I think that's definitely an area that I'm expecting we'll hear more about in the recent future. Quick question, Neeraj. I know, as a medical oncologist, you're not routinely treating these patients at this stage typically, but as a prostate cancer expert, you probably get questions from patients and or family members and others. Do you have general discussion or any points that you typically raise with them when talking about localized prostate cancer, local therapy for prostate cancer, or do you not spend so much time on this?
I agree with Tyler. Decipher, Artera can really help us in identifying patients who may be at a higher risk of having recurrence down the line. But we do not have any standard treatment for those patients. But this may change in the near future. So we have several trials in addition to what Tyler mentioned. So for example, guidance trial, which is using Decipher score to randomize patients to various arms. And arms are radiation therapy, RT plus ADT for 6 months, and then RT plus ADT plus darolutamide for 6 months. So for patients who have unfavorable intermediate risk prostate cancer, we know they are more likely to recur because of the biology. And then there are other ARPIs which are being used in several trials. For example, ENZA-RED trial. Primary RT or radiation therapy is being combined with ADT for 24 months plus minus enzalutamide. And then we have ATLAS trial where apalutamide is being combined with ADT. So I think we are going to see some of these trials at least being positive. And definitely I see increasing role of medical oncologist in this setting.
Yeah, absolutely. It seems like kind of paralleling the growth of active surveillance to de-intensify patients with lower risk prostate cancer, we need to learn how to identify and then appropriately intensify treatment for those with the more aggressive cancers.
If I may be a little bit provocative here, I think the way things are going is actually patients. So we just had a paper come out maybe like a week or two ago in European Urology Oncology. We're looking at active surveillance. And it always has bothered me in active surveillance studies that the endpoint is so uninteresting. Like where they progressed from grade group 1 to grade group 2. But I just said that most grade group 2s can go on active surveillance. Also, it's not very aggressive disease. And it probably was there anyway, and then you just missed it, and now you found it with a new biopsy, and that's not super interesting. Or if they progressed to treatment, they decided to go on treatment. Well, who knows why they decided to go on treatment? They may not have any worse cancer at all. They just got tired of the active surveillance. You biopsy too many times and it hurts, so they say stop. Which, by the way, wasn't required on PROTECT. Right? The active surveillance protocols that we developed in the US and elsewhere prior to a randomized trial being published were very conservative with good reason. But now that we have randomized data showing that it's very safe with just following PSA, we probably should back off on what we're doing for active surveillance in terms of invasive procedures. But anyway, that paper, we were looking at what are the things that were predictive of patients having a bad outcome, what we called an active surveillance failure. So they had either grade group 4 or 5, where now if they're getting radiation, they need 2 years of hormone therapy. We consider that a failure. So you don't want to have that happen to somebody who's on active surveillance. They obviously developed node positive disease, metastatic disease, gross extraprostatic extension, T4, any of those things, or they got treatment with definitive treatment, like say a radical prostatectomy, and recurred. So those would be the things where we said that's a failure of active surveillance. And then we looked at what were the features that were predictive of somebody developing active surveillance failure. And it really came down to just 2 things. Basically, it's if your MRI is positive, that increased your hazard. The hazard ratio was about 5. But the biggest one was if your cancer on biopsy had cribriform morphology, which included intraductal. But if you had cribriform or intraductal, it was almost 13 times higher. The hazard ratio was 13 for an active surveillance failure. If you looked at patients who had a non-visible, non-cribriform grade group 2, they were just like the grade group 1s. They never had failures. They were fine, right? So if we shift, and there's another really great study by Wen et al. In histopathology maybe 2 years ago that looked at cribriform and adverse pathology on prostatectomies and looking at patients that recurred or that had metastasis. But I think what's happening is we're identifying these adverse features where we said these are the patients that this is the kind of cancer that gets out of the prostate and metastasizes. And all of those are probably going to, at some point, I should say all, but many, maybe most of those are going to need some kind of multimodal treatment. So they're going to need medical oncology. If they have surgery first, they might need radiation and hormone therapy. I'm not sure, but it looks like that could be the case. And all of the ones that we were thinking we do so well with just surgery or just radiation, maybe the majority of those, if not all, can just do active surveillance. So we might be going in this direction. I don't know, but we might be going in this direction where either you have a cancer that can just be watched pretty safely, or you need all of us multidisciplinary care. Right? Those might be the only kind of 2 options.
Yeah, I think that's very interesting. I think for sure we need to refine some of these risk stratification tools and factors and maybe get to a place where we can stop treating people who don't need it and very aggressively and more successfully treat those who do. I think that's a fascinating paradigm that hopefully we're working towards. Well, let's move on a little bit to PSA recurrence after local therapy. So, let's say a relatively healthy younger man in the mid-60s with localized high risk or unfavorable intermediate risk prostate cancer undergoes treatment with surgery or radiation. Let's start with surgery and starts to have a PSA recurrence postoperatively. The traditional teaching, at least from when I was a resident, we talked about early salvage versus adjuvant radiation. At this point, PSA is starting to rise. We talked about trying to initiate early salvage therapy before the PSA gets too high. This was training in the pre-PSMA PET era. So I guess a question for both of you, maybe Neeraj first. When do you recommend PSMA PET in the post-local therapy biochemical recurrence setting?
Great question. Obviously, there's no consensus. I tell the patients whenever I see them for the first time with any PSA recurrence to start thinking about PSMA PET scan. Ideally, lower the PSA, better are the chances that we will be able to cure the patient. That's a bottom line. We can argue on 0.2 nanogram per mil or 0.02 or 0.5, but there are no level 1 evidence out there to support a PSA level to obtain PSMA PET scan. A bigger question is, what if PSMA PET scan is positive for, say, oligometastatic disease, 1 or 2 bone lesions, and CT scan and bone scans are negative? And that's a dilemma we are facing on a regular basis in our clinics. And in this context, should we diagnose them to have metastatic hormone-sensitive prostate cancer and treat them with indefinite ADT plus intensification or combination with ARPI plus minus chemotherapy, or treat them in the salvage setting with radiation therapy with intensification? So we don't know the answer right now, but there are 3 trials I'd like to mention really quick. So one is the, I call DASL high cap or DASL high cap trial, where patients who are receiving salvage radiation therapy, they receive ADT, which is standard, but then they also get, like, say, darolutamide for 96 weeks. So this is salvage radiation therapy, and we are not really getting into PSMA PET positivity or negativity. But the next question comes, which is PSMA PET is positive and conventional scans are negative. And do we really basically tell these patients that you are going to get indefinite ADT, basically castration for the rest of their lives? And I think answer may be not. And this will be answered hopefully by 2 trials, the ARA-STEP trial, where these patients are receiving metastasis-directed therapy and then they get ADT with darolutamide for a limited duration. So the concept changes from indefinite ADT plus ARPI to 2 years of ADT plus darolutamide and metastasis-directed therapy, in addition to any local therapy they may receive. And the Primordium trial, which is another phase 3, these are big trials, hundreds of patients, where patients are receiving radiation therapy plus ADT for 6 months, salvage ADT plus apalutamide for 26 weeks. So I think these trials will tell us in the near future how should we approach these patients. And I'm sure, Tyler, you are seeing these patients who have, like, say, 2 bone spots on the PSMA PET scan, a healthy patient. Are we going to tell them they're not eligible for salvage radiation therapy and they should be receiving ADT plus ARPI based on a test without much evidence? So this is the dilemma. Hopefully we'll have some answers.
Yeah, I agree. I could not agree more that putting patients on lifetime ADT, ARPI, it seems too much. And we need, at least I would say, if we're going to do that, we need to have established that that is important, right? That it's so much better than the alternative that it's worth the quality of life hit that you're that you know you're giving, and I don't think we have that right now. On metastasis-directed therapy, which we're excited about in radiation oncology, obviously, I would like to understand also the pros and cons of that and how much the benefit is and which patients benefit. We have, I'll mention a couple of IITs. In the de novo setting where the patient hasn't been treated yet, we have the TERPS trial that's Futran from University of Maryland has started, and we have that open here. So we invite patients to that trial, which is they get standard of care systemic therapy, they get radiation to the prostate, and then they're randomly assigned to either metastasis-directed therapy or not. And in the recurrent setting or de novo, we also have a trial. It's a basket trial that Raina McKay and I started here in San Diego that is actually across cancers, not just prostate, but we have a lot of patients with prostate cancer because that's what we treat. That is up to 10 metastases, starting a new line of systemic therapy. So they can have, it can be at the recurrent setting, it can be oligoprogressive, but whatever it is, you do the best imaging you have and you see up to 10 metastases, and we put them on systemic therapy, best systemic therapy, whatever the medical oncologist recommends, and randomize them to either receiving radiation to all of the visible sites or not. With this, again, idea that if we can kick the cancer back enough, maybe we can buy the patient time on the back end of their systemic therapy where they get a long break. And for some diseases, that is plausible that you can improve progression-free survival, either in prostate cancer by giving them a break from systemic therapy because they tend to do fairly well as a group, or in, worse, more aggressive cancers where we have resistance to systemic therapy arise very quickly, say like pancreatic cancer. Then the idea that killing off more of these clonal variants could improve our time to resistance.
And I'd just like to give a shout out to EMBARK trial which I see that trial just for our viewers, PSA doubling time of 9 months or less. And obviously PSMA PET scan was not there, but I assume these patients have PSMA PET scan positive disease. So if we can go back and do the PSMA PET scan on all those patients who were eligible for EMBARK trial, it is very likely we'll see PSMA PET positive disease for many of them. And we just saw the press release that overall survival is positive. And the way I look at this, look at the results, hopefully soon in one of the meetings, but that intensification with enzalutamide help these patients. So that's a message I am receiving from the EMBARK trial. Like you said, Parth, looks like even in biochemical recurrence setting, whether PSMA PET is positive or not, and I just mentioned few trials in the context of salvage radiation, I'm expecting more ARPI use in this setting based on all these trials.
Yeah, absolutely.
I think there's another one that I forgot to mention for the recurrent setting is the Alliance, the Indicate trial. Indicate is also looking at PSMA positive versus negative and then intensification with, I think it's apalutamide, but with an ARPI. So I agree that this is where intensification of the systemic therapy up front and addressing that problem, I think, is going to benefit a lot of patients more than just keeping them on ADT for longer periods of time. And I think the patients are open to it. They would rather be on 2 drugs for a shorter period of time than be on the one indefinitely. That's my impression.
Yeah, absolutely. Well, I think great discussion. Going back to PSA rising after local therapy for radiation, again, going back to my training, Phoenix criteria was heavily emphasized. And now in the era of PSMA PET, is that still relevant? Is there any reason to wait for 2 nanograms above the nadir PSA, or should we be starting to look for, potentially oligometastatic or local recurrent disease sooner? Tyler, any thoughts?
So we're talking about recurrence after definitive radiation.
After radiation,
right?
yes.
So after definitive radiation, now their PSA is rising, and our Phoenix criterion is 2 nanograms per milliliter above whatever the nadir was. That is still our definition, and so we don't have a better one, and we don't have a consensus on what we should be doing. And we don't know if we should be doing metastasis-directed therapy. What we do have some good evidence from phase 2 trials, STOMP and Oriole, that if you do metastasis-directed therapy instead of starting systemic therapy, that it seems like you can delay the start of systemic therapy and that's fairly safe. Those aren't huge trials, and it's not like we've proven that that's safe from an overall survival standpoint, but it definitely is a attractive option from a quality of life that we discuss. And if that's your strategy, then like was mentioned before, the lower the PSA, probably it makes sense that the better off you are. So to the Phoenix criteria, that's still what we're using. That's official. That's what I tell patients when they're done with radiation, because I don't want them freaking out about every little blip in their PSA as we're watching them over time, especially the ones who've been on ADT, because their PSA will rise, obviously, when their testosterone recovers. So I don't want them worried. But if I'm seeing a trend going up and we haven't hit 2, I'm not going to actually have a hard line on you have to get to 2 before we can get a scan. And if we get a scan at say 1.5 above, but there's this trend of we've had a couple of PSAs in a row, they're all kind of going up and you see what's happening, and then we get a PSMA PET scan and we see a metastasis, then I'm definitely not waiting until we get to 2. We're going to have a discussion about, do you want to go for best way of controlling the disease right now, standard of care from the longest time is systemic therapy, or do you prefer to kick that can down the road a bit if we can? We try by doing metastasis-directed therapy. If they're in the metastasis-directed therapy delay the ADT start group, then that's what we do. If they're all for systemic therapy, that's when we offer them the randomized trial again. We say, all right, start systemic therapy. I don't know if we should treat these metastases with radiation if you're already getting ADT and an ARPI, but it might be helpful. So we'll put you on the trial if you're interested. And then if they're randomized to that, then we do it up to 10 metastases.
Got it. So still quite a bit of room for judgment in the PSA recurrence decision-making.
And I'd like to add to what Tyler said. I have not come across a single patient who is enthusiastic about castration therapy. So I see a huge potential role of oligometastatic directed radiation therapy as a tool to delay ADT in these patients. So we often discuss with our patients, if we are getting oligometastatic directed radiation therapy, what is the role of ADT plus minus ARPI? And at this point, I'm leaning towards using oligometastatic radiation therapy to delay ADT. Tyler, as you said, this is, for me, the main reason for using or recommending ADT, oligometastatic radiation therapy. Because if you look at the ADT plus ARPI, they have great survival outcomes. So either I use oligometastatic RT or ADT plus ARPI. But I'm hesitant to use both at this point.
Yeah, we don't have evidence for that. I agree.
So I was taught many years ago that ADT makes the radiation more effective, right, by preventing DNA damage repair in the cancer. Is there potentially a role for a short-term ADT with oligomet-directed RT just for efficacy of killing the tumors? And there's not a lot of data in this space, but what are your thoughts?
I think it's reasonable. I agree with the concept of making prostate cancer cells weaker by taking away their fuel before we target them with radiation therapy. It makes a lot of sense. And I'm willing to use a short-term ADT plus ARPI. But again, it's a data-free zone. We don't have level 1 evidence. So again, in patient-specific, if I see, say, 5 or 6 spots on the PSMA PET scan being radiated, I'm more likely to use ADT plus ARPI for a short duration versus 1 or 2 oligometastatic sites which are being targeted along with salvage radiation. Well, we have the rationale for using 6 months of ADT anyway. I remain very reluctant to use long-term ADT plus ARPI in the context of oligometastatic radiation therapy.
Right. There was one trial that was just published recently. It was a phase 2 trial, Radiosa, that did look at this SBRT or SBRT with short-term ADT. And I mean, the main conclusion, I think you're not going to be surprised at all, that progression-free survival was delayed by adding ADT. So, which is, makes sense. It's great. It's good that it wasn't the other way because we would have been very confused. But then if you're looking at the patient's long-term outcome, right, how are they better off? Is it worth giving them that 6 months of ADT plus recovery time, which we know it takes a long time to recover. Some don't recover. What are we getting for that? And I just don't know right now. So I agree. I tend to do radiation alone for most of these patients. It makes the PSA easy to interpret, and we're honest about what we're doing. We're not pretending like we're curing you, because we have no evidence that we can do that at this point. But we're going to improve your quality of life by not overdoing the ADT up front. And that seems reasonable. But I do think that we could use some trials to figure out, would it be good to do 2 months of ADT with radiation? Would that be a good idea? What would you get out of it? What would be the recovery time? Would it be better if you used like a Reluvix and you could stop the effects of the ADT faster? Or should you do just an ARPI for a while? These are all reasonable strategies, but we don't know.
And I do see some
doing.
role. I know we have genomic sequencing as one of the topics. When I looked at the results from the Oriole trial, and patients who had these tumor suppressor gene mutations or more aggressive mutations like TP53, ATM, BRCA2, and RB1 loss, they were less likely to benefit with the oligometastatic radiation therapy. If I'm not mistaken, Tyler, this is your domain, but do you order these tests in your clinic on a routine basis?
Yeah, anybody with metastatic disease pretty much we're going to get genetic testing and then look to see if there's something targetable. And then, of course, that's much more your domain. But in terms of systemic therapies, we also are looking at some of those other rare variants. And there is a trial, I wish I could say we had it open here, but it is challenging when you have to have a genetic variant that's, rare plus, fairly niche slice of the population. But I want to give a hat tip to, again, Phu Tran and colleagues who did the Oriole trial, because based on the evidence that you're talking about, where they found this differential effect depending on the genetics, they have the KNIGHTS trial with the KNIGHTS, that's looking at salvage radiation in patients, oligometastatic disease with rare genetic variants in the tumor, and looking at addition of another drug. So I think it's a PARP inhibitor, if I'm not mistaken. But that's a really interesting biological and therapeutic question.
Because these patients are less likely to have long-term responses, metastasis-free survival if they have high-risk mutations. That's the bottom line. Yeah.
Right. So they might need multimodal treatment, and how to best combine and which treatments to combine. Those are open questions. The other open question, if you're talking about this population, we get a PSMA PET scan. I think the oligometastatic, and first I want to just remind everybody that PSMA PET positive means different things to different people. When we first got PSMA PET widely available in San Diego, I was seeing every week patients who were called oligometastatic, and I looked at the scans and I just was not convinced. The clinical picture didn't fit, right? And now we've learned a lot, but I still see patients, they've got a lesion in a rib, or there's like a smudge of PSMA avidity in a bone, and you have to be careful. We had ones where it was like, this is an oligometastatic patient, we have to treat it. And then so that looks like it could be a bone island or something. Maybe we get a biopsy. Oh, but the biopsies don't work. Okay, fine. Has this patient ever had a CT scan in the past? Ever? Yeah, 7 years ago at the VA and who knows where. Okay, get that image. You look at it and like that same spot was there 7 years ago, right? So we do need to be careful to not believe everything. Just because PET is easier for us non-radiologists, non-nuclear medicine physicians to look at and see something, we shouldn't believe that everything we see is cancer. But now I would say that what's beyond the oligometastatic picture, the other thing that it has done is that now we'll have somebody who has met that Phoenix criteria and they have a recurrence after radiation, but they have nothing on PSMA PET. However, they do have a bright spot in their prostate. So this is a relatively new situation, right? We used to have local recurrences, but they were hard to prove because bone scan's not very sensitive and CT's not that great. But now that PSMA PET is much more sensitive, we're starting to believe more, oh, this might be a local only recurrence. It might only be in the prostate. Always get an MRI as well, because MRI is better for looking at the prostate, at least much better than CT, and it helps us to see where the stuff is. So we can look, and if I see something that's concordant on MRI and on PSMA PET, and then we get a biopsy and make sure it's not everywhere and we just can't see it, but we have some disease in the prostate, Now we have to decide what to do for this patient who has a local only recurrence. And the stakes are high, right? Because if it spreads, then we're back to the metastatic disease. But if we treat a previously irradiated prostate, no matter what we do, there's a good chance that we're going to cause serious side effects. So this is a space where we really do need some good randomized trials. There are a lot of treatment options. You've got HIFU, cryotherapy, brachytherapy, SBRT, radical prostatectomy, which has fallen somewhat out of favor because of the side effects, but still is, we still offer it sometimes because some of these patients are willing to take that side effect risk to get cured for a high-grade recurrence. And it's an interesting thing that has become, it's because of negative PET scans, I guess is what I'm trying to say. Interesting that a negative PET scan has caused a whole new kind of thinking about treatment and a lot of interesting options. We spend a lot of time talking about these patients in tumor board and then multidisciplinary discussion with the patients about what the options are. Do you add ADT? Do you not? We really don't know.
Yeah.
But we do have some pretty good results with the various approaches.
Yeah, absolutely. I think it's a fascinating time in prostate cancer. Let's jump forward to high-risk prostate cancer and metastatic prostate cancer. If I may, alluded to a little bit, Tyler, you said all metastatic patients will get genetic testing. Is that germline testing? Is that somatic testing?
We would do both for various reasons, right? I mean, one, we're looking for rare variants that might, for example, make an indication for, say, a PARP inhibitor or something like that. But for cascade testing, for information for their children. So anybody with probably high risk at all is going to get both.
Okay.
And certainly metastatic.
So high risk localized metastatic. Neeraj, I assume patients you see with metastatic disease?
Absolutely. High risk, locally advanced metastatic disease. We order germline testing and tumor tissue testing, somatic testing as we call it. About 25% of these patients have HRR mutations. And then additional, I would say 5% of these patients may have TMB high, MSI high prostate cancers. And then we are not even talking about how to monitor these patients in metastatic disease setting. So if I see RB1 loss, P10 loss, P53 loss, more so with RB1 loss, these patients may not have PSA as the reliable marker for disease progression. On the other hand, if you have SPOP mutation, which are highly sensitive to androgen deprivation, I think PSA is a pretty good reliable marker for follow-up. So how often I should do scans in patients who are SPOP-driven metastatic prostate cancer? I'm comfortable with doing CT and bone scans once a year and mostly relying on PSA. But if I see P10 loss, P53 loss, both of them, or RB1 loss alone even, I tend to get CT scans and bone scans more often. Maybe every 6 months, every 3 months, every 4 months, no guidelines, but that's how I approach monitoring based on the testing results. And lastly, as Tyler, you mentioned, many of these patients, if they have tumor tissue testing, tumor somatic testing, positive for many of these HRR gene mutations, many of them will have germline mutations, and they can have implications on their family members. I can think about a 62-year-old man coming up with metastatic prostate cancer. We were just beginning to order tumor tissue testing or somatic testing in those days, 5-6 years ago, found to have one of the HRR mutations. Both daughters had BRCA2 loss, and they were saved by their father's cancer, the dad's cancer. So they are cancer-free. They never developed ovarian or breast cancer. They were at a very high risk of developing those cancers. So I want to actually go beyond and say these are no longer optional testing for us. We can have medical legal implications for not ordering the somatic and germline testing in our patients with metastatic prostate cancer.
Yeah, that's a fascinating point. I think, again, long gone, I think, are the days, at least at our academic center, we urologists rarely are managing patients with metastatic disease. I think we have such a good relationship with our medical oncologists, and I think that's true and probably in all of our centers. But I still remember from my training the days of urologists managing patients with metastatic prostate cancer, and so there's a lot of considerations, I think, for any urologists who are out there still managing patients with metastatic prostate cancer. To dive into that a little bit, we talked a little bit about genetic, germline, and somatic testing. Going back to the drawing board a little bit more, how are you risk stratifying these patients, the patients with hormone-sensitive metastatic prostate cancer? What factors are you looking at for risk stratification? And then sort of how does that inform decision-making about your first-line treatments?
So you're talking about metastatic hormone-sensitive prostate cancer based on conventional scan. Just for the clarity, I'll say based on conventional scans, because I do not necessarily diagnose them to have metastatic hormone-sensitive prostate cancer based on few lesions on the PSMA PET scan. So exciting time. And some of those situations do not have much data. So let's stick to conventional scan positive MHSPC. And I know we have traditionally used high volume versus low volume disease from the Charter trial, and then Stampede trial came and they used high risk versus low risk. Chemotherapy, because docetaxel chemotherapy was the first intensification agent to show improved survival, although its use never picked up beyond 10% of patients with MHSPC based on the real-world data set. And now ADT plus ARPI have literally become the mainstay as doublet therapy, if you will, for patients with metastatic HSPC. And I see the role of chemotherapy in those patients who have high-risk disease. So instead of getting into high volume, low volume, because ADT plus ARPI have never been compared with ADT plus docetaxel, and the triplet therapy with ADT plus docetaxel plus ARPI has not been compared with ADT plus ARPI. I want to keep it simple for my patients. I look for these high-risk mutations if they have these mutations. So my default treatment is for my patient, which I'm going to offer, is ADT plus ARPI. And then I look for a reason to add chemotherapy. See, if I see visceral metastasis, so liver metastasis mostly, if I see tumor suppressor gene loss, I'm more likely to use chemotherapy in addition to ADT plus ARPI, rather than going into high volume, low volume, because PSMA PET scan is changing the way you look at number of spots on the bone scans. So that's how I'd look at this. And now the question which is coming up is, can we de-intensify even in MHSPC setting? We don't have the data, but as patients are living longer, overall survival in metastatic hormone-sensitive prostate cancer is approaching 5 years from 2.5 years, just a decade ago. Now the question is, how can we save these patients from dying of cardiovascular disease, for example? So the competing risk of deaths are emerging as patients are living longer. So I'm so glad to see intensification and de-intensification trials have already started. So for example, the SWOG Canadian Clinical Trial Group trial is asking the question of adding docetaxel chemotherapy to ADT plus ARPI. So they look at PSA level of less than 0.2, so 0.2 or less at 6 months. And then if patients do not achieve a PSA of less than 0.2, they are being randomized to continuation of ADT plus ARPI versus ADT plus ARPI plus addition of docetaxel. So docetaxel should be used for all or should be used only for these high-risk patients. And then, of course, de-intensification trials are randomizing patients to continuation of ADT plus ARPI versus ADT plus ARPI as intermittent therapy. So coming back to SWOG's 9346 trial, which was started in 1996, Dr. Maha-Hussain presented those data in 2013, showing lack of non-inferiority of intermittent ADT versus continuous ADT. So continuous ADT became standard of care, but now we have to answer the question whether we can de-escalate ADT plus ARPI treatment in some of these patients. These are like 60% of patients who are going to achieve an undetectable PSA or PSA of less than 0.2. So I think these are very exciting times for treating our patients with all stages of prostate cancer.
This was a great summary of treatment intensification and de-intensification. What I didn't hear about was local radiation, prostate-directed local radiation in de novo metastatic prostate cancer patients. Where does that come into the picture for you guys?
Yeah, it's become so radiation to the prostate in metastatic hormone sensitive. I think it's become pretty much the standard. There are patients where we decide it's not worth it. They have enough competing risks, or there's enough already LUTS, like it is severe enough that you just decide it's not worth messing with the prostate. But for your typical patient, based on the STAMPEDE data, looking at, so just to remind everybody, right, STAMPEDE looked at they randomized patients with metastatic hormone sensitive prostate cancer to either radiation to the prostate using an almost definitive dose, but slightly less. So it's considered palliative. I mean, it's obviously palliative intent, but slightly lower than what we normally give, which was a fluke of the timing, I think. I mean, if they had known that it was safe to do 4 weeks of radiation to the whole prostate to full dose, even in the paper, they said we would have just done that had we known. But since at the time, it just seemed like doing 8-9 weeks of treatment was too long. So we gave a smaller dose in a shorter period of time. But it was almost what we give for definitive prostate cancer. So for metastatic disease, they randomized to giving the radiation to the prostate or not. And the trial was negative for overall survival. But there was a huge benefit for progression-free survival, which wasn't the primary endpoint, wasn't the reason to start giving the patients the treatment. But then in those with the low metastatic burden, which was based on the charted, which I don't think is the best definition, they had an overall survival benefit. So overall survival benefit for low metastatic burden based on charted, which is, basically if all of the disease is in the bones, in the pelvis or the axial skeleton, then they're low burden. So you can have a lot of metastases as long as the pattern fits. There was an overall survival benefit. That makes sense. So all of our low metastatic burden patients, certainly oligometastatic, we're treating the prostate with radiation. Then you have patients with more advanced disease, and you can refer to the piece 1 data showing that radiation decreased urologic events, problems with urinary function. And so there was even a benefit there. So for me, it's if they're oligometastatic, low burden of disease, for sure, I'm treating the prostate. If they have more advanced disease, I'm probably going to treat it, but I might not if, for example, I'm worried that they're going to have obstruct right now, then maybe it's better to talk about an outlet obstruction and see how they do on the systemic therapy and see if we really feel like it's necessary. But most patients are getting radiation to the prostate at this point, which then again begs the question, well, if I'm treating the patients will ask you, especially if they have low burden of disease, they will ask you, well, you're treating the prostate tumor and I have these 3 spots on the PET scan. Why are you not treating those 2? Can you not treat those 2? And that's where, again, we put them on trial because we just don't know. With ADT and ARPI, they're probably going to be just fine without any radiation to those bones. But in the long, long run, is it better to treat those? Maybe. So we have to find out.
Right. Or can it de-intensify the systemic therapy by treating those, or allow you to do more intermittent, as Neeraj alluded to, intermittent ADT plus intermittent ARPI, something like this?
Absolutely. I think in that, once we get to that intermittent question, then it goes back to what we were saying before with STOMP and ORIOL, where the metastasis-directed therapy might allow you to prolong those breaks. So whether you do it up front or, for example, do ADT and ARPI for, say, 2 years, stop, image, see where there's still active disease, because some of those, what you saw before, may not appear like they're doing anything anymore. So look for something that's active on the new PET scan now and treat all of those spots with radiation before you resume systemic therapy. I mean, I think it's a very reasonable idea. Again, we have evidence, strong level 1 evidence? Of course not. But I think these are the kinds of trials that we should be doing to improve quality of life in patients who are doing well with systemic therapy.
Absolutely. I have to ask Neeraj just one question mostly out of personal interest, and I admit I haven't kept up with the literature here, but I remember a few years ago, bipolar androgen deprivation therapy caused a bit of a commotion, and there's some promising early data about actually doing testosterone replacement during the intermittent ADT times to, potentially potentiate the prostate cancer to subsequent ADT. Is there any update on that? How is that being used now? Is that something that's an active area of investigation still?
Yeah, so I was one of the co-authors of the Transformer trial, so I can talk about that. But the whole concept was started by Sam Denmead in Hopkins, and I know one of those trials is likely moving forward in one of the cooperative groups. I think Mike Schweizer is going to lead one of them. So story is still ongoing. We do not know the final, we don't have a final consensus yet in the absence of level 1 evidence. But one thing I like to highlight is that I was surprised to see in the Transformer trial, patients who got, say, one of the ARPIs and then they got randomized to high-dose testosterone versus another ARPI. But then those high-dose testosterone patients, when they receive standard of care ARPI after that, about 30% of them had a great response in their PSA, better than the alternate ARPI the other arm had received. So definitely there is a subset of patients who are going to be candidate for high-dose testosterone therapy. And by the way, patients love it. So the key is to find out who those patients are. And I'm sure those great minds are working onto answering that question. So I'm sure we will hear more about bipolar androgen deprivation therapy because they continue leuprolide and then they get this high-dose pulse testosterone therapy. So I really hope something will come out of it.
Yeah, I wonder if it'll introduce some interesting questions about what's the trade-off that patients are willing to accept in terms of if this improves quality of life, but maybe leads to even a slightly worse survival or progression-free survival. I imagine I've certainly seen patients who might be happy to make that trade-off for the added quality of life of that high-dose testosterone period or periods that they may be able to enjoy. But again, being mindful of time, I don't want to go too far over. I want to move on very quickly to castration-resistant prostate cancer and talk about, what is in your minds currently the standard of care for this, acknowledging some very exciting recent data on overall survival that I saw from the TALOPRO-2 trial a couple of days ago. So Neeraj, maybe you can tell us a little bit about your thoughts on this.
MCRPC setting continues to evolve very quickly. So at present, we have ARPIs and a lot of patients, especially who are progressing from high-risk localized prostate cancer. In the US, majority of patients are diagnosed to have localized prostate cancer, not de novo metastatic hormone-sensitive prostate cancer, unlike in many other parts of the world. And these patients get surgery, radiation, both receive ADT for short duration, and then their testosterone don't recover in many of those patients. And when they develop PSA recurrence or PSA rise, many of them have MCRPC or CRPC because they still have low testosterone. In fact, we presented in AUA last year, 2024, based on Flatiron database, that only 35% of patients with newly diagnosed MCRPC had been exposed to any ARPI, exposed, not progressed, prior to onset of MCRPC. So there's a large population. So I still keep ARPI as one of the therapy options in MCRPC setting. And then we have chemotherapy, docetaxel, cabazitaxel, and then carboplatin for those patients who have neuroendocrine differentiated prostate cancer or AR indifferentiated prostate cancer. And then for small cell type, we don't want to get into that rare disease, and we treat them like small cell lung cancer. So coming back to the traditional garden variety MCRPC, we have ARPIs, we have taxanes, now we have new addition, lutetium-177, Pluvicto. And then this is just a start, I think. We just saw exciting data with T-cell engagers targeting KLK2 in ASCO, made a lot of news. I know phase 3 trials have already started. And then we have actinium as another RLT, which is going to be used. I personally think it may be better tolerated than lutetium, the beta particles, alpha particles, given their nature. Without delving too deep into this, they may be more well tolerated and may have lower long-term side effects. Again, no comparison yet, than the beta radiation particles. So definitely will have some role down the line. But then there are different types of beta particles. So rosapatamab based lutetium-177, which only require 2 doses of lutetium-177. That trial is ongoing, sponsored by Telix. I'm involved in the trial, so just giving a shout out maybe. And then we are talking about other T-cell engagers, AR degraders, AR mutation, AR amplification remain a driver of prostate cancer progression. So based on that, I think there will continue to be a role of AR inhibitors, the new forms of AR inhibitors. And who knows, they may replace the current ARPIs, second generation ARPIs down the line. So think about an AR degrader, which is going to bind any AR, regardless of what kind of mutations they have, and target them to proteasomal degradation, and is way more effective than, say, just for the sake of discussion, the current ARPIs. Why not to use them in upfront setting? So, and then CAR T cells, again, small niche population, small number of trials. We have not seen high level of activity yet, but I remain optimistic about immunotherapy. And this is, as I said, these are all in different phases of trials. And of course, I was going to talk about PARP inhibitors. There are 25% of our patients who have these homologous recombination repair mutations. And we just showed in the TALAPRO-2 trial, they had 14-month absolute overall survival benefit when talazoparib was added to enzalutamide in the mCRPC setting. And then these PARP inhibitors are moving into frontline setting. In the form of Amplitude trial, we saw the results presented by Gerd Attard in ASCO. And then we will be seeing the hopefully results of TALAPRO-3 trial down the line. And then there is a small number of patients, TMB high, MSI high, prostate cancer, who have great response to pembrolizumab, which is a highly well-tolerated treatment. And definitely I keep an eye for those mutations because they can have really great benefit with immune checkpoint inhibitors. So field is going to continue to evolve very rapidly in the next 2-3 years in the castrate-resistant setting.
Wonderful. Tyler, anything on the horizon in the more advanced prostate cancer setting from the radiation standpoint?
Hard to say. I mean, there are a few things. I think one is still going back to the oligometastatic. If there are few enough targets of visible disease, is there a benefit to adding radiation to those so that the systemic therapy doesn't have to do such a big lift by itself? It could work. I think there's some logic to it, but we need to do the trials to find out if that makes sense. There was a phase 2 trial looking at just, say, bone metastases. This wasn't a prostate cancer only trial, but prostate cancer has a lot of bone metastases. So there was a phase 2 trial that was looking at high risk bone metastases, like high risk for fracture. So in the spine, acetabulum, these kinds of things. Was it better to do radiation right away, or do you wait for symptoms? And, there was that trial showed a benefit. There was also even a survival benefit, which is, a bit hard to swallow. Might be true, but it was really small numbers, so we wouldn't count on that necessarily. But the phase 3 follow-up of that is now live. So that's a big cooperative group study to look at. Should we be more proactive about giving palliative radiation? And then, of course, you have the radioligand therapies that we've been talking about. It would just remind, these are radiation. And so if they are working, it does kind of strengthen the theoretical argument for maybe incorporating more of this molecular marker agnostic kind of therapies, radiation being one of them, where we're trying to just kill the cancer cells directly and perhaps don't have to worry as much about resistance as a complement to, I think, which has to be the backbone, are these systemic therapies. So whether it's a radioligand or an external beam, I don't know, it's the same type of treatment, but adding those may be useful in that setting to get more bang for your buck out of each line of therapy. I think that's the role that we could potentially help with, is to just keep them on that second line for longer and then the third line for longer so that we don't burn through all our options so quickly.
And I'd just like to add another setting I feel really excited about is to use these radioligand therapies in oligometastatic setting as a way to delay ADT. And there are many patients who will be very interested in this approach down the line.
Yeah, that makes a lot of sense. It seems like in the oligometastatic setting, the challenge is in targeting, right? And a radioligand with bound to a targeting molecule or something, sort of overcomes the limits of what we can target with imaging. So I think that makes a lot of sense to me.
And that becomes more exciting with the newer agents like the actinium, the alpha emitters, because the beta emitters, the concern is that you won't have enough. If you don't have enough of a, kind of a critical mass of tumor there, then you won't have enough radiation to kill with the beta emitter. But if you have an alpha emitter, then you could do a better job with micrometastatic disease.
Very good point.
So hopefully that plays out.
That's your engineering background talking, Tyler.
That's paying attention. That's actually paying attention to nuclear medicine. That's Louise Emmett teaching me things. Yeah, Oliver Sartor. Those are my friends teaching me how to think about the big picture in a better way.
Yeah, well, speaking of friends teaching you things, I could listen to you guys talk about prostate cancer all day, but I do want to be mindful of your time. So thank you so much. This has been a really wide-ranging conversation about prostate cancer, but very valuable. Thanks again, and I'll look forward to seeing you guys in person soon.
Thank you.
Sounds great. Thank you.
Take care.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable URO on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
thanks again for listening and see you next week.